el doctor Campbell, pues, es neurocirujano, de acuerdo, es con más de 20 años de especialización y nos va a traer el tema de disfunción espinal. Doctor Campbell, desde que pueda hablar.
Well, thank you very much for asking me to speak. I'm going to talk about the treatment of, sorry, let me go back to the beginning. Treatment of myelomeningoceles, going just briefly through kind of standard of care, and then talk about some of the newer things that are still points of controversy in terms of modern treatments for children born with myelomeningoceles. As I'm sure you all know, this is a disorder of primary neurulation, which happens around the 23rd day of gestation. The incidence is somewhere around 1 to 5 infants per 1,000 births. It's there's a fair amount of regional difference in terms of what that rate is. There appears to be a reduced risk with prenatal folate augmentation. Cuts the incidence probably in about half, although that data is a little bit murky, because at the same time that a lot of the trials were done for folate was also a time when prenatal ultrasounds became more common, and so more pregnancies were also probably terminated for myelomeningoceles. As you all know, there's neurologic dysfunction below the level of the defect. There's near universal neurogenic bladder, and the impact on the rest of the motor system is really highly dependent on the level. So kids with thoracic level myelomeningoceles traditionally don't have leg movement. Kids with sacral myelomeningoceles, as this is a picture of, often have relatively good leg movement and good mobility, good walking as they get older. The standard of care is closure of the defect at around the first day or two, and really the primary reason for this is protection of the neurologic function. So prevention of infection, because the sac is often quite thin or even leaking CSF, and also the end of the cord, the placode, is in the sac, and so there's a worry about damage to the placode. Again, roughly 80 to 90% of these kids will develop hydrocephalus. There's some debate about this, but it seems that the lower the level, the less likely you are to develop hydrocephalus, so that there's some studies suggesting that sacral myelomeningoceles have closer to a 50% risk of hydrocephalus. The etiology of hydrocephalus in this population is not completely understood. And we'll talk about the posterior fossa in these kids in a second, but there may be blockages at the fourth ventricular outlets, at the posterior fossa, arachnoid, subarachnoid spaces, or at the incisura. And this hydrocephalus may be more common when the defect is leaking CSF at birth. And it often progresses after closure of the defect. And so a fair number of babies are born without hydrocephalus, and then in the weeks after closure can develop progressive hydrocephalus that warrants treatment. The traditional treatment for myelomeningoceles has been, for hydrocephalus from myelomeningoceles, has been a VP shunt. And again, we'll talk a bit more about that. Many of these babies have Chiari Two Malformations. In the postnatal closures, it's probably close to 100% of babies, and Chiari Two is causal descent of the cerebellar tonsils and vermis, but also associated with a host of other things. So you get a small posterior fossa, you get a low-lying torcula as part of that. You tend to have a large foramen magnum. You have a large master intermedia, so the master intermedia is quite large. You tend to get kinking of the brainstem and beaking of the tectum. And while this is essentially ubiquitous, essentially all babies, most babies don't develop symptoms. When they develop symptoms, you typically get lower cranial nerve dysfunction. So swallowing dysfunction, disordered breathing. Babies can almost sound like they're barking when they're with their cries, and that's from vocal cord abnormalities. And something that's become apparent over time is that Chiari Two Malformations are most commonly symptomatic when the hydrocephalus is not well treated. And so the treatment for a symptomatic Chiari Two malformation is to make sure that you've treated the hydrocephalus. And in the majority of kids, those symptoms will go away. Chiari decompressions are actually rarely indicated or needed in this population. So I did my my training, my pediatric neurosurgery training at Boston Children's, and Mike Scott, who's the chief of pediatric neurosurgery there, liked to say that he had never decompressed a Chiari Two because 100% of the patients he had seen had the symptoms had resolved with treatment of the hydrocephalus. The other neurosurgical thing that we worry about in a longer term is tethering of the spinal cord. So the spinal cord plateau is always scarred into the surgical closure. And for most kids, this is not a problem, but for roughly a quarter of kids, they will experience deterioration over time due to symptomatic tethering. This is most common in the elementary and middle school years. So I always tell families it's most common in the sort of 5 to 10 year range. Adults with spina bifida can get deterioration as well. This is most commonly seen in the face of trauma. So this is most commonly, so in the kids, we see kids get kind of slow, steady neurologic changes. In older adolescents and adults, we tend to see sudden deterioration due to car accidents or falls or trauma that suddenly hurts the end of the spinal cord. The most common symptoms we see for tethered cord are change in bladder. And so these kids are followed quite actively by our urologists who do urodynamic studies and such to keep track of bladder function, and then also gait changes for kids who are able to walk. And the treatment for symptomatic tethered cord usually is re-expiration and untethering of the spinal cord. So it is going back in through the surgical scar, freeing up the plateaued, you will see in most studies, by far the majority of kids will have either no further deterioration or most commonly even some improvement. Although, I'll tell you just parenthetically that bladder changes are less likely to improve than gait changes. So the nerves to the bladder appear to be particularly fussy and less likely to improve with a tether cord operation. So really, what I wanted to more talk about was some of these newer controversies in treatment, and that really falls into two different categories. One is the prenatal closure of myelomeningoceles, and this was originally done open, and now there are fetoscopic techniques for closing myelomeningoceles. And then also the role of endoscopic thermotracheostomy in terms of treating hydrocephalus. So we'll talk about kind of the most recent knowledge we have about this. So prenatal closure of myelomeningoceles really started in the in the 90s and early 2000s. There were several centers that started doing it, and then this became part of a randomized trial with 3 sites within the United States called the MOMS, which is the Management of Myelomeningocele Study. And so other centers in the United States made the decision not to start doing prenatal closure of myelomeningoceles and to have just 3 centers run a randomized trial. This ended up randomizing 183 children between either prenatal, and this was an open technique, and a postnatal closure. Something of note is that over 1,000 women were screened for this trial, so that less than 20% of women actually ended up getting enrolled. And that percentage has actually continued on past the study, where the majority of people who are screened by centers for prenatal closures end up not having prenatal closures for various reasons. The inclusion criteria, I won't go through all of them, but it was pregnancies between 19 and 26 weeks gestation, otherwise healthy moms, otherwise healthy babies, etc. The primary outcome measures was fetal death or need for a shunt by a year of age, and then a developmental assessment at 30 months. And then here are some of the secondary outcomes that they looked at: surgical and pregnancy complications, neonatal morbidity, mortality, the Chiari 2, time to first shunt, locomotion, functional impairment, and using the WeFIM as a degree of disability. And so if you look at their primary outcomes, so the prenatal surgery had a favorable outcome in terms of the first primary outcome, which was the need for a shunt. And so they actually did this both by the actual placement of shunt, and then also they had an expert panel that reviewed the charts in terms of whether or not they felt the shunt was indicated. And so the primary outcome is actually that number is when was a shunt indicated. And so roughly 30% fewer kids were indicated for a shunt in the prenatal surgery versus the postnatal surgery. So so if you look at the top number here, it is 68% in the prenatal surgery and 98% in the postnatal surgery. The actual placement of shunt was different. And so the actual placement number of patients getting placed were 40% in the prenatal and 82% in the postnatal. And I'll tell you that lower rate of shunt placement, 40%, was somewhat of a bias. This was clearly not a blinded study, and there was the belief that the surgery should prevent hydrocephalus, and so families who had the prenatal surgery seemed to be more resistant to having shunts placed. And I know this just from having seen some of these kids after their surgery. So, and then in terms of development, there also was an advantage in terms of development. This is primarily from the difference between motor function and anatomic level. So they estimated the level of myelomeningocele on prenatal ultrasounds and then compared it to the actual motor function after birth. And in babies with prenatal closure, they appear to have a greater positive difference between their motor functional level and the anatomic level that was estimated on prenatal ultrasound. But then the flip side of the story is the complications. And so these are maternal complications showing that this is not without cost to the mother. And I'm not going to go through all of this, but you can see that that there was a fair number of maternal complications that were recorded in that population. And then there were complications for the babies as well. And so again, this first column is prenatal, the second column is postnatal. And so you can see that the majority of prenatal babies were born prematurely. And so you had both the neurologic issues related to the myelomeningoceles and then also the medical issues related to prematurity. So this was not without some cost to both mother and to child. Another point is that tethered cord operations are rare during infancy or toddlers, but in this study, while this did not reach statistical significance, 8% of the babies who had prenatal closure underwent a tethered cord operation during follow-up, as opposed to 1% of the babies in the postnatal group. And this is a story that is still in development in terms of understanding whether or not the quality of the closure is different and the risk of tethered cord as babies get older is higher because of that. You do a shorter, quicker operation because of the risks of the hysterotomy during the procedure. So some thoughts about this. So there may be a functional benefit for certain children. So especially if you're talking about mid-lumbar level with evidence of leg movement on prenatal ultrasound, there may be a benefit in terms of walking, locomotion, et cetera. The benefits for hydrocephalus is a little bit less clear. So if you have hydrocephalus at the time of prenatal closure, it does not give you a benefit. So if the ventricles were at least 15 millimeters in size, there was no less likelihood of needing to treat hydrocephalus. And then also, the use of endoscopic third ventriculostomies decreases the burden of shunts, and we'll talk about that in a second. For many children with spina bifida, the burden of a shunt is one of the higher burdens that they live with throughout their childhood and even adulthood. But if you can avoid that burden by doing an endoscopic third ventriculostomies instead of placing a shunt, then that may really diminish that advantage for prenatal surgery. It did improve the number of kids with Chiari Two Malformations and the severity of the Chiari Two Malformations, although there's historically been few kids who experience morbidity from this, although the kids who do experience morbidity can experience significant morbidity. So kids with symptomatic Chiari Twos that are not caught quickly are the ones that end up needing to be have gastrostomy tubes placed and tracheostomies so while this is uncommon, for the few babies who have significant morbidity associated with it, it's significant morbidity. But there is real and significant morbidity to both mother and baby with prenatal closure, and so you add prematurity to the burden of the spina bifida. There have been more recent attempts at changing the fetal closure to using fetoscopic techniques, so a much smaller hysterotomy, a much longer and more arduous operation by description, and it appears to have fewer maternal and baby complications than open techniques, but that's still an area that's actively being looked at. And then turning to endoscopic third ventriculostomy. So endoscopic third ventriculostomies were really first popularized in the 80s for treatment of acquired aqueductal stenosis. So initially, the group that seemed to be most beneficial are children over the age of 2 who develop aqueductal stenosis. The success in this group is probably 90% or greater. And while there are early failures with third ventriculostomies, the risk of late failures seems to be pretty small. So there are occasional late failures, although they're all within usually 5 years of surgery. But the risk of late failures is much lower than with shunt. There's also a decreased risk of infection. As we all know, shunts carry an infection risk. In the United States, that infection risk probably hovers in the 6 to 8% range if you look at good studies. While third ventriculostomies carry really the same risk of infection of regular surgery, since you're not leaving anything behind. The other thing is third ventriculostomies are a more physiologic treatment, and so that shunts overdrain, and as a consequence of that, particularly shunts placed in babies, sometimes as babies get older and become teenagers, they have slit ventricles and can run into difficulty with treating their hydrocephalus because the shunt has created more problems. Third ventriculostomies don't do that. Third ventriculostomies are really designed just for people with obstructive hydrocephalus to get the CSF into the space where they can reabsorb it. And then starting around 2000, third ventriculostomies really started to branch out into other patient populations. And this was with and without the cauterization of the chorial plexus. So cauterization of the chorial plexus is a technique that was described in the 30s for treatment of hydrocephalus before the invention of the shunt. So as you all know, much of the CSF is made of the chorial plexus, and so if you can cauterize it, you can diminish the amount of spinal fluid that you make. It turns out that you probably diminish it for a period of time, although not permanently, until you probably cut the amount of CSF produced by maybe 50% for some number of months or maybe a year. But in certain patients, particularly younger patients, it seems to improve the success of third ventriculostomies. ETVs are a particular value where patients might have trouble accessing medical care in a timely manner. So one of the biggest proponents of ETV with cauterization of the chorial plexus is a neurosurgeon that I used to work with, Ben Worf. He spent 6 years in Uganda treating babies with mainly spina bifida, post-meningitic hydrocephalus. And he started doing ETVs with CPCs as his first line treatment for all of them, because he worried about putting shunts into babies who weren't going to be able to get back to medical care in a timely manner if the shunts were to fail. And particularly, for example, in Spina Bifida, shunt failure has a relatively high association with death. Because of the Chiari 2, people with shunt failures can stop breathing, and if they don't have access to medical care in a timely manner, can be fatal. So there is, Dr. Kulkarni has really pushed what's called the ETV Success Score, which looks at the likelihood that an ETV will be successful. And it really is based on three components. It is patient age, the cause of the hydrocephalus, and whether or not the patient has previously had a shunt. And so from each column, you pick the score to the left and then add those scores up. And so if you are greater than 10 years old with aqueductal stenosis with no previous shunt, that would be a 90% chance of success, so 50 plus 20 plus 10. Now for Spina Bifida, if you're a newborn with Spina Bifida, this would claim you only have a 30% chance of success, although that's not necessarily what has been found in the literature, and we'll look at those numbers in a minute. This is kind of a bit of a busy slide, but it's really looking at, this is from the Hydrocephalus Clinical Research Network, which is a network of big children's hospitals in the United States, where they have come up with standardized protocols to look at various outcomes with the treatment of hydrocephalus. And this is the use of, these are Kaplan-Meier curves for the use of endoscopic third ventriculostomies with quarter plexus cauterization in different groups of patients. And so the top left is their babies with myelomeningoceles. B is post interventricular hemorrhage from prematurity, C is aqueductal stenosis, and D is other etiologies. And you can see that the Kaplan-Meier curve there would suggest actually the success is a little bit higher, so that so in the red line is less than 1 month. They ended up with about a 50% success rate. They had relatively few patients in the 1 to 5 months, and so you can see how jagged the Kaplan-Meier curve looks. But in the biggest studies looking at ETV for myelomeningocele, so probably the first big one was published by Dr. Worf and myself back in 2008, and that really looked at his experience in Uganda with 115 infants. 93 of them were treated with ETV and CPC, and in that patient population, there was a 72% success rate for ETV with CPC in this population. And if you include kids who went back to the OR for a redo ETV at the time of first failure, 78% of the kids were shunt-free during follow-up. So that's over 3/4 of kids without shunt. There was another large study from France, which again looked at the role of ETV in myelomeningocele. This was 32 patients, and they had likewise a similar success rate of around 70% in this patient population. Just in terms of doing an ETV on these babies, the anatomy tends to be a little bit different, and so this is actually a very nice paper from, actually it's from Turkey, looking at, they had done 450 ETVs on babies with myelomeningoceles, and they point out some of the things that are unique. And so there tends to be a very thick and prominent mass intermedia, as we know from the MRI scans. There tends to be a relatively thick floor to the third ventriculostomy, and there tend to be inner hypothalamic adhesions, and so the anatomy is a little more murky than a regular ETV on an aqueductal stenosis kid, and is probably best done after one's had some experience doing ETVs on more normal anatomy. Again, the procedure, this is from Dr. Ward's paper, mine also involves cauterization of the choroid plexus. So this is choroid plexus here. This is an electrocautery, coagulating it, including the thalamus striate vein, and then also making sure you get to the opposite side, so going through the septum pellucidum and doing this similar procedure on both sides. And so, so sort of in conclusion from both those topics, given the risk and benefits of prenatal closure, both I think are reasonable, and it really depends on the child, the infant. And so a baby without leg movement probably does not, on prenatal ultrasound, probably does not benefit as much from a prenatal closure. However, a baby with leg movement and a lumbar myelomeningocele might benefit, but then it depends on the risks that the mother and that the parents are willing to take. So when I see parents with spina bifida, I talk through this with them and try to make sure that they understand the risks and benefits of both closing the myelomeningocele prenatally versus waiting until after birth to close the myelomeningocele. And then shunts are a significant source of long-term morbidity in children with myelomeningoceles, and this can be avoided with an endoscopic ventriculostomy in somewhere around probably 2/3 to 3/4 of babies with myelomeningoceles, and it's probably the procedure of choice for the treatment of myelomeningoceles in most parts of the world, and including in the U.S. Although that has gained slow acceptance in the United States. There's probably a third of children's hospitals that do ETVs as their primary treatment for myelomeningoceles, but many still do not. But endoscopic ventriculostomies are really a great operation for hydrocephalus from a number of causes. Again, particularly in much of the world where there might be difficulty with accessing neurosurgical care in a timely manner. And so that's what I had, and I certainly welcome any questions.
Muchas gracias, doctor Campbell. Muy interesante su actualización en cuanto a esta patología. Preguntas que surgen, pues, usted mencionó algunos del porcentaje que hay con tercer ventriculostomía que hay que ser repetidas. ¿Hay factores que usted asocia con ese fallo o predictores que podemos identificar que nos pueden llevar a ese fallo?
Doctor, ¿podría repetir la pregunta para ayudarle con la traducción?
Sí, claro. La pregunta va dirigida con respecto a los factores que tienen que ver con los fallos de la tercer ventriculostomía. Si el doctor puede identificar o nos puede comentar algunos factores que hacen llevar a tener que repetir la tercer ventriculostomía en estos pacientes con myelomeningoceles o Chiari 2.
Okay, so that's going to be a tough one. So he's asking if are there any factors that may cause failures in the third ventriculectomy? What are those that will make you redo or reassess or retreat the patient with Chiari 2?
Yeah, so third ventriculostomies in a newborn myelomeningocele is really dependent just on sort of anatomy, and so how so there are times you may look at the floor of the third ventricle and not feel comfortable with doing a third ventriculostomy, and at that point when I do third ventriculostomies I always prep for a shunt at the same time, so that if I were in the surgery, didn't feel comfortable doing third ventriculostomy, I can just place a shunt. In terms of a kid with thermotracheostomy and symptomatic Chiari 2, what I would typically do would be to re-look at the ETV visually. So I would put an endoscope back in, see if the ETV is still open. If it's not open, would then reopen it. If it is open, then place a shunt. And so, you know, shunts do drain more. And so in theory, you'll get smaller ventricles and probably less caudal descent of the cerebellar tonsils or the cerebellum as a consequence of less CSF within the intracranial space. Although there's not any evidence that you're more likely to be symptomatic from a Chiari 2 after an ETV than you are after a shunt.
De acuerdo, muchas gracias. El doctor Santiago Valenzuela hizo una pregunta, pero es muy similar prácticamente a lo que el doctor estaba hablando. Entonces, gracias, doctor, por someter su pregunta. Otra pregunta que surge en cuanto al tema de las médulas ancladas. En esos niños en los cuales se ha hecho la reparación y se le da seguimiento para ver si desarrolla médula anclada, ustedes hacen...
Qué bueno que se han quedado a compartir cada uno.
Se está haciendo de manera rutinaria la imagen, de la neuroimagen, ya sea de médula lumbar o dorsal, aún en pacientes asintomáticos, o solamente se manda a hacer cuando ya el paciente empieza a presentar síntomas.
For patients that later present anchor spinal cord, do you do a visual assessment through imagenology or any type of procedure with those type of patients, or you wait for the development of the child? What is the approximation?
Yeah, so everyone with spina bifida has a tethered cord, and so it's just a question of whether you're symptomatic or not. And so, you know, back in the 80s when MRs first became available, a lot of babies with spina bifida underwent tethered cord operations because people got the imaging and then got worried. And so what we do now is really follow for symptoms. And then if there are symptoms, we often get an MR really as preoperative planning more than anything else, just so we know what things look like when we get in there. But the imaging does not drive the need for surgery. The only time imaging might push you towards doing something is if you have a new syrinx or you know, so like I've seen some kids where their symptoms might be change in their sitting balance, and you get an MR and they've got a new syrinx, and so that's a time when the imaging might push you a little bit more towards surgery. But most of the time it's based on symptoms.